So now let's get started with today's program, A Clinical Leader's Guide to Defining and Executing a Smart Room Strategy, sponsored by AvaSure. We're joined today by Emily War, Administrator, Center for Telehealth at the Medical University of South Carolina, and our host, Brad Smith, Principal Product Manager for AI and Interoperability at AvaSure. Welcome, both of you.
Thanks for having us.
And with that, I'll hand to Brad to begin the presentation.
All right, let's dive right in. Emily, thanks for joining me. As you know, there's a lot of conversation around smart rooms, but one of the challenges we found is that two health systems can use the exact same term and mean very different things. So I'm going to ask you a bunch of questions, and we'll see how much we can answer in our short time frame. But I'm excited about this. So first things first. Rather than starting with technology, I really want to start with a bigger picture. What does a smart room actually mean?
Gosh, Brad. So, in our experience, we've been talking about smart rooms or intelligent rooms or in room equipment for many years now, sort of as a conceptual idea or aspirational goal. And I think different people in different areas of healthcare have different ideas about what a smart room means. And so, to me, I think it's not about the technology in the room. It's not about the camera or the monitor or the cart. We've in the Center for Telehealth at MUSC, we've been cart based for years. Are actually a very helpful way to get services started and access out to patients all over our state. But does that define a smart room? And I don't think the answer is yes. I think it's more about sort of the strategic approach and the problem you're trying to solve. So to me, it's about uh, what are we working toward in the room to make a more seamless patient experience. I think hospital rooms largely for, I don't know, 20 years, 30 years haven't changed much, but the environment that we provide care in has changed drastically. We have a lot more data infrastructure. We have care teams have become much more complicated. And so, figuring out how to level up a room in a hospital setting to be able to achieve a seamless, high quality, highly reliable sort of patient experience is what we should be thinking as we think about a smart room. Now, again, a definition that I give you might be very different than one that someone else would have, and I think it's evolving in that way. But an important sort of strategic discussion that should be happening in health systems across the country.
So you mean to tell me that there's really not an industry definition going on for smart room?
I don't know. Ask AI, ask ChatGPT. I bet it would tell you what it thinks a smart room is, right? But no, I don't think there's a standard definition of a smart room that every clinician and hospital leader and technology leader would agree upon.
Well, you've been pretty definitive about this in our conversations. So would you say a smart room is a strategy or a collection of technologies?
I think it's a strategy. I think it's a strategy for a couple of reasons. I think it's not a silver bullet. A smart room is not going to solve the clinical problems that you face, and so you have to pin the smart room sort of design and solutions to your strategic objectives. And I think different hospitals have different strategic objectives. I think aligning with those is really critical for the success of a smart room. At MUSC, it might look different than it does at Kaiser or at Stanford, and that's okay. I think it's much more likely to be successful if it's aligned with the strategic objectives of MUSC. Access is a huge objective of ours, improving access to patients in our hospitals all over the state, and even patients beyond our hospital infrastructure across the state. And so, access would be within our smart room strategy. How do we use a smart room to access expertise that is not physically located within a certain market, right? Patient experience is a huge part of our strategy as an organization. We want to improve the patient experience. We want to improve the provider experience. And so those have to be key sort of goals or objectives as we're making a decision about strategically building out a smart room. Workforce optimization is another thing that's really sort of top of mind at our organization, and I think across the country. And so, how does a smart room help all of our care team members work at the top of their license, and really help us optimize the workforce of the future, knowing that we have the constraints that we do. And then again, high quality care is of critical importance in our organization, and I think in many others across the country. And so, how do you tie quality and sort of integrity, reliability into your smart room strategy?
So if you could say one thing, imagine, I'm a successful health system leader, I'm got a suit on, got a jacket on, and I'm just beginning the journey. What's something you could tell me about, what's one thing you can tell me to do to help start my journey?
I think it's get started, I guess, is the first comment I would make. Our experience has been with something as big as trying to design a smart room strategy for a health system that has 16 to 20 to 30 hospitals seems daunting. And so I think it's important to just get started. I would suggest, based on what I've just said to you, to start with a strategy and aligning with the strategic priorities of the organization, and I think in doing that, you have to bring in the right leaders across the organization to at early on in the process to help you build out functional sort of not only technology but workflows, clinical workflows to make the smart room work for you as an organization. Those key leaders are obviously nursing leaders, the chief nursing officer, the CFO, financial officer has to be involved because you gotta be sure that you can have the budget to execute a smart room strategy. You need your patient experience officers, whatever sort of responsibility of patient experience and provider experience, wherever that lives within the organization. Those folks need to be involved. Bedside staff, of course, has to be involved. So, and sort of where you pull those folks in along the journey can be different for different organizations, but upfront, early and often, I think would be a strong suggestion without overcomplicating it. I think it's important to try to keep it high level and aligned with strategic priorities so that everybody can stay focused.
Yeah, I like what you said about not overcomplicating it. One of the things that we've recognized and everyone's probably recognized is there's just so many technologies being labeled a smart room. How do you really decide how do you decide what should not be in a smart room? How do you keep it from becoming one big technology wish list? Because everyone's got their needs, but and everything's smart nowadays. But how do you decide what to take out of your smart room strategy?
Mhm. It's a great question, Brad. I think it's going to be iterative for most of us. At what even if you had what you thought was a perfect smart room equipment list
Mhm.
today in 2026, and in 2028, there are going to be items on that list that differ from the list that you have now. And so I think there are a couple of things that I would say about that. Go ahead and get started. It's not going to be a perfect smart room when you get started, but you will learn and you will evolve based on what you learn. The technology that's available in a couple years is going to be very different than what is available today. So interoperability and open infrastructure is really important to be able to layer on new technologies, better technologies as they come along. And so those sort of it's kind of a non-answer, but it's a higher level sort of general principle of making the smart room a sort of a living organism whereby you can add new functionality over time and you can pivot based on what you learn within your hospital system. I think it's also reasonable to consider that what works from a endpoint specific technology in one hospital in a rural setting might be different than what works and is needed in a academic medical center that's part of the same health system. So I don't know that it has to be one size fits all. And again, that's where sort of that open infrastructure and agnostic approach to endpoints can be really helpful as your strategy evolves.
Yeah, I like that approach. Like a good open, like don't close your doors. Like you may not be able to fit things into your budget or fit things into your technology initiative, but buy something that you can expand upon. It's really good,
Mhm.
really good strategy. Um, so thinking about this, you previously during some of our preparation conversations, you mentioned the phrase configurable smart room. So kind of in this context, what does configurable mean to you?
I think configurable sort of builds on what I was just saying about open infrastructure. In the same sort of spirit of open infrastructure, configurable allows me to name my own adventure to a certain extent as a health system. So, the historically, I think pre-pandemic, partnerships with telehealth or virtual care, digital vendors were sort of out of the box products. You get what you get, and you don't throw a fit kind of approaches, and that worked for some period of time because there wasn't a whole lot of creativity and nimble evolution in the space. Now there is, and so just like open infrastructure is important, so is the ability for MUSC as a health system to configure our smart room technology, software and hardware, to be able to solve our unique needs. And that configurability is enduring, right? Because if I can configure it now, then 2 years from now, when I want to layer in AI ambient listening or in-room observation or whatever the new tool is du jour, then I have the ability to configure my workflows and alter them in a way that helps me solve the new problem, because we know that there will continue to be problems. There's problems we don't even know that we're going to have a couple of years from now, and so we need to be able to have work with partners who allow us to be configurable, or their software to be configurable, so that we can have sort of an enduring and living organism that is a smart room. Does that make sense?
Yeah, yeah, and I like how you said it. Some folks might be ready for AI, some folks may not be ready for AI. Let's make it configurable so that you can add it on later. Do you have any other examples of, in addition to AI, of kind of something that one health system or one hospital may want configured versus differently than another?
Sure, yeah. So, I think a good example within our health system is some of our community hospitals that were in our within our system need access to a virtual consultation of specialists. But our academic medical center has a wealth of specialists who are here local on site, and so they don't need that access. So, configuring a workflow for beaming in a neurologist or a palliative care physician into a rural hospital, it has to be available within the smart room strategy. It does not necessarily have to be available immediately within the smart room strategy in the academic medical center. So, I mean, I think there are lots of examples like that, though. Sitting is another good example. The ability to use a virtual sitter approach is more necessary in certain settings than in others. And so I sort of think of smart room software in particular as a chassis whereby
Mhm.
you can sort of plug in the tools that you need at any point without altering the foundation that you built, the integrations that you've gained, and the patient and provider experience. So if you have a new AI tool that everyone would love to try, but you don't have the time or maybe can't even afford to try to purchase that and run different integrations into your EMR, you plug it into the smart room sort of chassis, if you will, and the patient and provider experience stays the same with the improvement or sort of leveling up of the functionality.
Your comments make me wonder. I feel like you've lived through the fragmentation side of things. So anyone who says configurability means that they've lived through the worst. So what did technology fragmentation, actually look like in your environment before?
Well, I think yeah, I mean, and I fragmentation still exists. It's everywhere, and we as the healthcare industry sort of catches up to the digital transformation that banking went through 20 years ago, right? As we sort of catch up, fragmentation is everywhere. We in the Center for Telehealth, we experienced kind of intentional fragmentation historically as we built out very service related products on different software and hardware platforms because of the problem that they were solving. And we needed that specific type of technology for, say, telestroke or for tele ICU or for our virtual urgent care service offering. Those three services were on three different technology stacks. And so that was fragmentation, particularly as we came out of the pandemic and we had providers in each of those settings cross covering to a different sort of location of care, like visits into the home, virtual video visits into the home. And so they were on two different technologies for that. So at that point, we figured out, hey, we gotta come through with more of a platform approach. We've got to try to collapse some of this and have more interoperability for patient experience, but also to support our providers to be able to toggle back and forth between different locations of care and types, of service that we offered. Um, it's interesting. We're, as I mentioned, it's still fragmented. I think full interoperability and is aspirational, right? I mean, a smart room that is fully interoperable with all of the softwares available in the hospital and is idealistic and aspirational, and I'm really excited to see it come. But we got to work at it, and there's I think we have years ahead of us before we get there. Fragmentation is something that we chip away at as we try to collapse, and that's something that we are very much in progress with here at MUSC. I'm sure that's similar to our colleagues all over the country.
Yeah, if you could talk to those colleagues, would you consider, they may have fragmented environments as well, as you stated. Would you look back and say that that was a mistake, or is it just part of the journey?
I think it's part of the journey. I mean, we have a strong learning culture here. I mentioned earlier, like, don't overthink it. Just get started. Start small if you need to. Start, with a single unit to try to learn. So the fragmentation and the point solution approach in our ecosystem 10 years ago taught us a lot. In one way, it taught us, the things that we like about certain workflows that and what we will in the future would end up asking to configure in new software partnerships. So I think it was the journey was important, and the learnings along the way it helped us create a more thoughtful sort of smart room strategy going forward.
You mentioned the word interoperability now, and granted, it's also kind of something near and dear to my heart. Why do you think interoperability is such an important piece? And I know you've answered this and throughout the other questions, but I feel like this is really strong. A very strong answer here would be is needed because in my mind, interoperability is key. I just want to get your take.
I'm a nurse by background, and quality of care is very important to me because of my background and because of my role at MUSC. And it is well known in the healthcare community that the handoffs in like a nursing handoff from one shift to the next is the one point in care where the most mistakes are made, right? Because it's communication. We know we have errors in communication. It's a handoff from one to another. It's no different for technology that isn't interoperable, right? There are things happening in this system over here, there are things happening in this system over here, and unless the two are integrated, interoperable, able to communicate and function as a team, then there will be mistakes, there will be errors, and we are in an industry that mistakes are not acceptable. In a high reliability organization, we need to be addressing those failure modes, those failure points. And when you rely so much on digital solutions, as healthcare is beginning to sort of catch up to relying on, we have to have them communicate in a way that we describe as interoperability, but in a way that doesn't negatively impact our care team or our patients, because the two are not able to cohesively offer care support for our patients.
Yeah, I'll say, open platform sometimes sounds like a promise that everything magically talks to everything. In your mind, would you call interoperability aspirational in your point of view?
Yeah, I mean, I think so. Just yeah, just like a sort of a seamless care via a smart room is aspirational. I think we've got a ways to go on interoperability. I would hope that most of the vendors in the market in healthcare tech market are looking at how to work more cohesively and in an interoperable way with their even with competitors, because I think that's how we do a better service to our patients. But it's not easy. I mean, I think just even getting integrations with our EMR can be really challenging and time consuming. And so when you're asking outside of that, beyond the integrations to have two softwares figure out how to communicate with each other that were created and with very different strategies and methods is difficult. So yeah, it's aspirational. But it is a worthy effort to continue to pursue because it's the right thing to do for our patients. And if healthcare is to catch up with some of the other industries in the world and digital transformation, I think we have to figure out how to do that.
With that said, do you feel it's, more important to have then an architecture that really gives you a true path to integrate and evolve?
Yes, because of what you just said, the evolve part. We have to continue to evolve, and if you have an architecture that is locked down or proprietary, it's challenging. I'm not going to say it's impossible, but I think what I've learned over time is it is unlikely that everything that we as a health system want and is on our roadmap is going to align perfectly with a single vendor partner's roadmap. And so the ability to offer up some open infrastructure and interoperability allows technology companies to focus on what they're best at while still allowing their customer partners to integrate things that may not be within their strategic roadmap but are important in a smart room strategy, for example.
Very nice. So let's take that word evolve. How did you how did you think about building a smart room strategy that could evolve over time rather than becoming obsolete? It's really easy to think about, something that, hey, I've got this and this is when it's going to end, but you've used the word evolve. Like how did you do that?
Well, I guess I don't know, the word evolve means that you start with, what you have and you make changes over time. And so that, we've tried to do that here. I don't know that we've evolved as quickly as I would have liked, but one of the ways we do it is I'll give you a specific example. As we've explored our smart room strategy and execution of that strategy, we've tried different things in different locations. And one of the areas that we implemented was in a children's hospital that was state of the art, built in 2018, 2019, and with the best equipment, really, really nice tech within the rooms. And our smart room sort of philosophy and strategy has evolved more recently. And so we've gone into that equipment and tried to upfit it for the goals of today for the smart room with some successes and some sort of failures. We learned, for example, that the computers that were on the smart TVs in those rooms we just were not able to manage the software today, and so we had to upgrade those. But I that's evolution, right? That's taking what you got and making iterations to make it more viable, learning from it, and continuing to iterate. Better cameras are on the roadmap for those rooms as well, with because pan tilt zoom is excellent and important, but cameras evolve relatively quickly too. And so getting upgrading those cameras is likely to be on the list next. But that doesn't mean that we're not trying other things in other locations, right? So that's sort of it's a evolution, but all the pieces and parts aren't necessarily the same in each location within our system, if that makes sense.
Yeah. Yeah. And you kind of talk about evolving the technology, but how do you do it without ripping everything out and starting over? Like as new things come out, you got a new camera, now you've got to rip the old camera out, you've got a new piece of equipment, you've got to change things. What's an example where you evolved it without actually having to do all of that work?
The children's hospital example is one, being able to go in and look at the equipment that was available and start by working with what we had and then trying to find the sort of failure points within that workflow to decide which pieces of that actually needed to be replaced. I think there are lots of different ways that you can navigate a smart room with existing softwares that perhaps the hospital purchased. Ways that the hospital communicates with patients via the TVs in the room, et cetera. And sometimes that works nicely, and sometimes it can be a barrier to actually accessing the patient in a timely manner for a virtual visit, for example. So those are all things that we've learned along the way and evolved. Our The nuts and bolts of our strategy as we've had to sort of meet the rooms where they are, use the equipment that's available, and continue to improve. It's very expensive to
Yeah.
outfit a 2,000 bed hospital system with the exact same equipment at the same time, right? And so I think in the spirit of getting started, it's important to take perhaps a unit that has good, perhaps not perfect technology, but good technology in the room and get started and see what you can make happen there and then evolve.
And that to me, that feels kind of like a really important distinction. You've learned something wasn't optimal, but the answer wasn't really replace the entire room. How important is that kind of component level flexibility when you're thinking about a multi-year strategy?
Very important. I think that because of the realities that we face with operational budgets, right? I mean, I think figuring out how to budget for a big project like this is daunting, and if you are able to use some of the equipment that you already have, and open infrastructure philosophy, you can play with the pieces and parts that you have in certain locations and learn from what works and not have to spend multi millions of dollars at one time without having lived experience. I think often absolutely have had this experience. What we thought we were going to see in the sort of visioning stage and strategy stage with equipment did not play out as we thought it would. And so, shame on us if we go spend $10 million and then learn that the equipment doesn't work or the software doesn't work as expected. So, starting small, using what you have, replacing and learning is we've learned is a good strategy to overcome that.
So, you've spoken about kind of the role that open platform plays in enabling future innovation. One of the things, though, is what should organizations actually ask vendors if they really want to understand whether or not that the flexibility that's being touted is real?
It's a good question. Because I think because it is aspirational for a lot of us, I think it's easy to say, sure, yes, we can do that. I mean, in my experience, talking to a potential vendor partner about use cases where they have been able to integrate, better understanding what resources they're going to put into that interoperability, where it sits in their long-term strategy. Like, I think if you talk to a potential vendor partner about what the next 5 years looks like for them, I think you can tell pretty easily if interoperability, open infrastructure, sort of the integrating with the best of the best going forward is something that they meaningfully want to contribute to, or if they're more interested in sort of a closed architecture. So it's asking a series of questions. It's getting to know the potential partner better. And we always suggest to form those partnerships and keep them as long-standing partnerships and evolve and work together. And so when you're picking a vendor partner, I think it's important to know what's on their strategic roadmap, what types of interoperability projects have they done historically, and what are their goals, going forward in that space.
We've talked about defining what a smart room means. We've talked about evaluating current technology strategy. We've even gone as far as to building the future ready smart proof strategy. Um, Big question though, who should ultimately own the smart room strategy across an organization?
I think it's different at different organizations. So, um, at MUSC, we have a large Center for Telehealth. We're very involved in this process. Now, would I say we fully own it? No, because there are other stakeholders that have key ownership elements as well. So I think it is shared. There's got to be somebody driving the strategy and holding everybody accountable to the strategic principles and the guidelines and guardrails of what it is that you're trying to do, particularly in a phased approach. But it could look like a digital transformation officer at one site. It could look like the information solutions group, or the EMR leaders,
Mm.
who also may have an innovation technology arm. It could look like your chief experience officer who's over patient experience, and whose key drivers, and key performance indicators are related to scores that patients give us after their stay in our hospital. And how does the smart room strategy, and operationalization of the smart room strategy, how does it impact those scores? So who sort of is driving the train, I think could be different at different organizations, but it's important that you have all of those players engaged at a high and meaningful level, for the whoever is leading it to be successful. Ultimately, it is a big enough infrastructure type purchase and strategy that you need a lot of leaders engaged and helping push it forward.
So maybe it's less about finding the one perfect donor and more about making sure the right people are genuinely at the table.
Mhm, mhm. And accountability, for everyone to put forward their best resources and efforts to see it be successful. But I think it also, and going back to, how you're aligned with your enterprise strategy, if the key strategic objective is access, I think you may choose a different leader than if the key strategic objective for the smart room initiation is patient experience. Or
Mhm.
if it's quality. If it's quality of care, then you might choose your chief quality officer. So I think it sort of depends on what the key elements or the North Star is within your strategy, who you sort of assign with this big old task.
Well, we've kind of talked about making sure the right people are at the table. Let's actually talk about a different table, the boardroom table. Uh, so, what does the CFO actually care about when evaluating a smart room investment?
Um, how much it costs? How much it's gonna save him or her, I mean, I think we hire CFOs to keep us accountable to budgets and to making sure that our finances are, appropriate for the work that we're doing, that revenues are good, and that our expenses are managed. And that's their job, and we need them to do a good job. And so it's only fair to bring forward when you're presenting to a CFO and the other sort of players in the C-suite, to bring forward real dollars, whether that's in savings. The workforce in healthcare is the most expensive part of a health system's budget, right? It's generally the biggest line item. Nursing, even bigger than any of the other care team members. But of course, the physicians are. And their sort of experience is important, and it's an expensive part of the CFO's sort of
Mm.
budget, right? So figuring out how to save money where we can. A couple of examples of that, virtual nursing can help reduce costs associated with travelers, agency, also with turnover. We've been able to assess those things and actually bring those back, and so that's helpful. I think with physician staffing, oftentimes, smaller rural hospitals aren't able to afford 24/7 neurology coverage, for example, because they can't hire four neurologists or five neurologists. And so being able to show that we're saving the hospital money by offering them a sliver of a neurologist, but coverage 24/7, is a way to show cost savings. And then also, pulling that thread through, that helps keep patients local in those hospitals, the DRG stays, the revenue associated with the patient being admitted stays, et cetera, et cetera. So I think you got to find real dollars, and you got to show that the strategy that you're deploying is intentionally going to impact those things. Up front, when you're trying to get approval, that is a proposal. You can put together a
Yeah.
pro forma. You can show what it is that you intend to do, but it's really important, of course, to come back and show that you actually have over time.
But you talked about bringing in leadership from patient experience, from quality, wanting to, you think about kind of the benefits that are very real, but really tough to put in an ROI spreadsheet, such as patient experience, clinical experience, access, quality, reliability. How do you handle those? Those are very real benefits, but
Yeah.
CFO, I feel like, wants to see, a nice ROI spreadsheet and, as you said, pro forma. But
Well, that's why there are other players in the room, right? The chief quality officer is around to make sure that quality is a priority of our institution as well. So, I mean, I think the CFOs understand, of course, that experience is important. Trying to sort of take that analysis to the next level is where we are in our organization now. We're trying to see, so if virtual nursing, for example, is able to improve the quality of care by decreasing our risk around some of the nursing sensitive quality indicators, if we're able to improve our pressure ulcer incidents or reduce quality and CLABSI, there are dollars associated with those infections and reduction in those infections. And so spending a good amount of time sort of figuring out what the real cost savings are for those is an important exercise. I would suggest dedicating somebody to doing that analysis over time, showing the before and the after, because it's only theoretical unless you are able to tie it to the actual outcomes and the dollars associated with them.
So obviously, it takes a lot to move, the mountain of things that need to happen to start your smart room strategy. What was your approach to gain executive buy-in? How did you start to even climb that mountain?
I think it was get started again. We started with a presentation, we started with an idea. We had the benefit of having a significant amount of telehealth service already at play in our
Mhm.
organization. We have hundreds of carts that roll around our health system and have historically. And so the leaders in our organization already understood the value of the service element of it. And so we were able to move into ways to improve the efficiency of the service elements with in-room technology and a smart room strategy. I think if you're an organization who doesn't have a whole lot of virtual service yet, that's where I would start. I would start with explaining the workforce optimization opportunity, the access opportunity, the quality of care opportunities, and how your services that are ultimately going to leverage the smart room strategy and the technology will benefit the organization. The service ultimately is the most powerful part of any sort of smart room strategy, in my opinion, because it's what will actually improve access. Will work to improve the workforce. Will improve the quality of care. And hopefully, over time, will improve patient engagement and experience as well as provider experience. That's where I would start.
Perfect. So, kind of, one of the things the point that I liked hearing is the socialize it before that board meeting. It's worth emphasizing the
Mhm.
executive meeting really probably shouldn't be the first time the stakeholders are hearing the strategy.
Yes, that's a great point. I mean, that's where those having those key leaders and stakeholders involved in the conversations in advance and feel bought in. You don't want to walk into the boardroom with a surprise, $7 million investment without having done some of that grassroots effort and also due diligence in what how to really align this strategy with the service needs and the strategy of the organization.
So one of the things you kind of emphasize in this is the involving the nurses and physicians much earlier as part of the getting in the buyers and stakeholders. Why is it important to involve kind of the clinical side of things?
Because they're who is going to be most impacted, right, by this. There are, I guess, really 3 groups that are most impacted by, service into a hospital room. The patient, the patient's family, we'll consider that one, the nursing staff and care team, and then the providers. And so if it is, um presumptive and bold to think that we could outside of that work we could create a model that was better for those individuals without their feedback, right? So and I think it's important um to bring clinicians in early, so it's less of a feedback and more of a sort of integral to the building of and of the model. Who you pick I think is really important to bring into those conversations because every nurse and physician is the best clinician is not always the best sort of innovator or best with change management and sort of seeing what the potential is. And so picking key nursing and physician leaders and bedside clinicians who can see the vision and are excited about the opportunity, but also are going to hold the team accountable to workflows that make sense for the patients, that make sense for the nursing staff and for the providers. So it's not something that I think every staff member is going to be really excellent at, seeing the vision and giving feedback. But there are key players on every floor and in every medical staff, I think, that can help significantly and still keep the innovation on track.
And I really love that point. Your best clinician isn't always your best change champion. But really, what's the difference between asking clinicians for feedback versus truly involving them in the process?
Well, I mean, I think it's if it's only feedback at the end of the build, then that's insulting, right? Because you've already decided that my workflow as a bedside nurse better than I do, and you think you can make it better. And now you're presenting this to me and saying, "What do you think?" And that seems right out of the gate like you didn't value my opinion, or you would have asked me, you would have come and
Mhm.
shadowed it, better understood what it was that I did and what my pain points were and how I would suggest that we fix it. And so I think, the feedback part is really important, but that's way down the road. Up front, in the phase where you're developing the strategy and you're thinking about what you're going to tackle first, you need key clinician stakeholders in the room. I think it can be everyone, but you need key stakeholders. And then the communication with the bedside staff, once you do go get that feedback, is that you've had that representation involved since the very beginning. It helps with trust, and it helps with sort of brings the guard down when you're trying to talk about how to make it work for clinicians across the organization.
So, where have you seen organizations get that clinician involvement wrong? Even when they generally thought they were involving clinicians, it was the wrong approach.
I mean, I think that every implementation is different. Some go more smoothly than others. In our evolution over time, we've had some that were not as smooth, and I think that largely the human factor
Mhm.
um, was the reason that they didn't go as well as others. And the ones that went really successfully, it was that also the human factor. It's the people. It's always the people. And so I would say focus heavily on getting the right folks in the room, engaging them up front in the strategy, making sure they're aligned with the strategy and are bringing solutions that help solve that problem. It'll go a lot better.
So, I mean, we talked about building alignment with clinicians, but how do you build alignment with with nursing, IT, finance, medical leadership? You've got all these people you're trying to get alignment, trying to bring them to the table, but and even operations, but they're all kind of coming to the table with different priorities.
I think again, if that's where the strategy can be so helpful, right? If you can agree on what your strategic objectives are. For us, it's about patient provider experience and improving that. It's about quality of care. It's about workforce optimization. It's about access. If you have those elements that you can get the group to buy in on, then as long as your sort of implementation journey is aligned with those objectives, I think it's easy to maintain that buy-in. Where you go off the rails is when everybody doesn't isn't bought into those strategic objectives, or you begin to squirrel away from those objectives, and then people will, I think, will start to squawk, and rightly so. And so I think that part is really important. The other reality is everybody's not going to love the idea. That's just human nature. People There are going to be people who have feedback that the organization and the leader ultimately doesn't take, and they're not going to like that. But I think we can feel good about the initiative and the implementation if we set a strategy, we stuck to it, we put the patients and the providers first, and we were trying to hit those goals. And you bring folks along over time, as required.
Awesome. Well, let's gonna, I know that we've been talking, chatting for a bit, and I want to appreciate your time. So let's finish it up with a couple of quick ones. So imagine you're talking to a health system on a webinar, with Brad Smith, and that health system is beginning their journey next month. What's the very first conversation they should have?
I think they need a strategic plan. I think that's the first conversation that they need to have. I think they need to sit down with their key leaders, whoever going to be the drivers of the implementation, and decide how this plan helps the health system achieve its strategic goals and what the guiding principles are going to be. Start there, get aligned on that, and then I think the group will feel empowered to make the decisions that'll be required as you go forward. But it's easy to get lost, I think, if you haven't taken that first step. And seek out, change agents and innovative folks from the bedside at all levels of leadership who can help champion the initiative. They will ultimately be the ones that help you win hearts and minds in the army of nurses and physicians and APPs that are going to be using the smart room technology. And so, I think it's really important to spend time choosing the right folks to help you lead the initiative at the bedside.
What's the biggest mistake they should avoid?
Picking technology first. The reverse of what I just said. If you come in with a list of specs of the things you want to put in the room, and you give it to a team and say, figure out how to make this work because it looks really fancy, and we know the patients will love it. That is the opposite of how I would suggest that you build this out, because it's easy to sort of get a good amount of pushback on that, because somebody else is going to come in and say they would have chosen a different, setup, and it's not focusing on the right thing. It's not about the setup in the room. It's about the service. It's about solving the problems. It's about aligning with the strategic priorities of the organization. Once you have those elements in place, then you go choose the technology. So that's the biggest mistake. Technology first.
All right. So imagine 3 years from now. Tough for me. I don't even know what I'm going to eat for lunch. But 3 years from now, what do you hope healthcare leaders think a smart room really means?
I don't know what they'll think. I mean, what do I hope? I hope they think that it is a way to improve the patient experience, timely access to expertise that is necessary for their care. Um, it helps our clinicians work at the top of their license and brings joy back to the work that they do by taking away some of the stupid stuff. I mean, those are the things that I hope. I don't know if that's what it'll mean. I imagine there'll be differing experiences depending on how the implementation goes and what folks focus on. But I think this is a great opportunity that we sit with here, with this smart room strategy. And if we execute it well, then in a few years, we will have been able to transform in at least a small way some of how we deliver care in the hospital setting.
Well, I think that's a perfect place to leave it. Things are going to keep changing, but your strategy has to be durable enough to absorb that change.
Mhm.
I will say, Emily, thank you so much for sharing the real world perspective you have and the lessons you've learned along the way. Always enjoy our chats.
Yeah, thank
Anything
you.
else you want to leave the audience with?
I don't think so. Just go, be brave, get started, and have a strategy.
I want to put get started in a big poster
That's
board
right.
behind me.
That's right. Get started. Just get started and learn.
At this time, we do have to wrap up. Emily, Brad, thank you both for all of your insights.
Thank
Thank you
you.
so much.